Can I start, Anmol?
Yes, you can.
Okay. So, good evening, everyone. This is the first of the glaucoma webinars which we have planned. It's in Glaucoma Diagnostic. It's under aegis of MOS, and I would like to thank the Maharashtra Ophthalmology Society for allowing us to do this webinar. Every session has one international speaker. So today we have Michael Girard. He's one of the authority on AI and ocular biomechanics. So I will just introduce all the speakers and the panelists, and then we will go to the first talk. So Dr. Michael Girard is Associate Professor at Duke NUS Medical School, Singapore. He's the Principal Investigator at the SERI. He's Head of Ophthalmic Engineering Innovation Laboratory. And he has expertise in ophthalmic engineering with focus on AI, biomedical imaging, ocular biomechanics, and ophthalmic devices. And he has more than 120 papers and some of the fantastic work, I would say. Has received numerous research grant and research award. Then we have lots of our national faculty. Gauri, she's a senior glaucoma consultant at Bangalore Prabha Institute. And we know all, so I'm not going to go too much about every national faculty because we all know Gauri very well. We have Professor Sushmita Kaushik. She is the professor in PGI Chandigarh. And her main interest of research is congenital glaucoma. We have Ganesh Raman, he's head of Department Glaucoma, Arvind Eye Institute, Coimbatore. Prashant Bhatia is a senior consultant, Vista Healthcare, Dubai. Parul Icha Pujanani is associate professor in Department of Ophthalmology, Government Medical College, Chandigarh, and she has tremendous academic work, lots of chapters and textbook. Sachin Dharwadkar is a senior consultant, Mumbai. Is a very good friend, and he has a very good academic interest in glaucoma. Not only glaucoma, he likes to read a lot. Shweta, she's a senior glaucoma consultant, Lucknow, Indira Gandhi Eye Hospital and Research Center. Shefali Parikh, she's a co-moderator. She's medical director, Srijaya Clinic and Palak Glaucoma Care Center. She's a GSI based on representative. And me, and I also will co-moderate with Shefali. So I'll just finish fast because we want to concentrate more on the glaucoma discussion rather than having introducing each other. We all know very well. So I'll request Michael Girard to start his talk. Dr. Girard, please take over.
Okay, thank you very much for the introduction and invitation. It's a pleasure for me to be here with you guys virtually. Unfortunately, it's difficult to meet in person these days. I will share my screen and I hope you'll be able to see my slides full screen now. Is it okay? Can you see the slides?
Yes, yes, we can see it.
Okay, great, great. So, and I have 20 minutes, is that correct? I just want to confirm.
Just 20 minutes.
Okay,
perfect, 20 minutes.
Perfect. So I'd like to tell you a bit about artificial intelligence and biomechanics in glaucoma and how the two can be merged actually to improve glaucoma diagnosis. Before I start, I'd like to tell you my financial disclosure. So I do own a startup company in Singapore related to AI in glaucoma diagnosis. So I think it's important for me to disclose this. And, you know, before I start my talk, I just wanted to show you like a cool image of what AI thinks is biomechanics. So maybe some of you may not be familiar with biomechanics, but biomechanics really relates to any forces in the human body, like the intraocular pressure and how it impacts the organs of the bodies. This is really what biomechanics is about, the merging of biology and the mechanics. And if you ask AI, this is just an AI application. What does it think it is? AI biomechanics. What does it think in it? It will create this painting, which is beautiful. Which, you know, this came just completely randomly. This is a completely artificially generated image when you question an AI algorithm. So they're getting quite smart. I mean, we can already see the shape of an eye and the biomechanics, like the futurish features, right, around it. So I think this is pretty cool of what the AI algorithm will be able to do in the future. So glaucoma, we know a few things about glaucoma. We know that it's damage at the back of the eye. And we also know that the axons that transport light information from the retina to the brain, where they pass through that very beautiful tissue called the lamina cribrosa, which is a very porous tissue. And we know that the lamina cribrosa is anchored to the sclera. And we know that those two tissues, the lamina and the sclera, they deforms continuously. Every seconds, they deform due to change in intraocular pressure, because the intraocular pressure is not constant within the eye. And we like to think that maybe glaucoma could be caused by damage, mechanical damage to the axons, whether it's direct or indirect. And I'll mention more about this. So I like to say, usually I like to start my talk by saying that glaucoma is a mechanical disease. But we still don't really know exactly what it is, right? So this could be glaucoma. As an example, you have too much pressure in your eye. The tissue cannot bear the loads, and you get an expansion, right? This could be glaucoma. We have fluctuating pressure, right? The ocular pulse, you know, the pressure is pounding on the optic nerve head all the time during the day. And if your sclera is stiffer, you're gonna get a bigger insult. And maybe this could be glaucoma, you know, the continuous insult over a very long period of time. We know that we have eye movement, you know, and there's a cable that links the eye to the brain, and that cable could get damaged, maybe, and that could be a pathway for glaucoma, but it's still very debatable at the moment. We know that there are opposing forces in glaucoma. There is IOP on one side and the CSF pressure on the other side, and the orbital fat pressure, and all these forces are opposing each other. And of course, all this pressure, they may affect the blood flow. You may get ischemia. They may affect the axonal transport. So there's a very, very complex mechanical environment around the nerve end. So if we want to understand glaucoma, one of the messages, we're really going to have to understand the physics of the eye. And if it's true that mechanics really play a role in glaucoma pathogenesis, so why not create a test, a clinical test, that will tell us whether a person has glaucoma and whether their optic nerve head is robust or not. And we might also be able to predict the progression of future visual field loss. So this is what we did, you know, using optical current tomography, that just commercial device. We've been looking for a long period of time at the mechanics of the optic nerve head in vivo. You know, so we've been using ophthalmodynamometry, so it's a gentle test to press the eyeball to the eyelid to increase IOP, and we'll see the optic nerve deform beautifully in 3D. And maybe from those kind of deformation, we might be able to learn, you know, is this a glaucoma eye, or is this eye is gonna get glaucoma? And we've been testing hundreds of eyes in Singapore, about 800 eyes. We've been mapping those deformation. And if I zoom in a few of those eyeballs, you see each optic nerve here is deforming due to pressure. And you can see, you know, at the bottom, some optic nerve deforms a lot, you know, and maybe at the top, some of the optic nerve deform a lot less. So there's really a huge spectrum of deformation. And this information, we don't use it clinically as of today. We don't use any information about the robustness of the optic nerve to make a glaucoma diagnosis and to tell you whether the patient is going to progress. So we're making the claim that maybe we should be looking into this, because our past studies, and this was a study that was done in London that showed us that those deformations are correlated with visual field loss. This was done in the London population. We repeated that in Singapore, same thing. All those deformations are associated with visual field loss. And this is one small population in Singapore. And recently, it was a larger population, about several hundreds, high tension glaucoma and normal tension glaucoma eyes, that we still observe this relationship. And that relationship was much stronger in high tension glaucoma. So the mechanics might also tell us a subtlety about the different glaucoma types, and might explain us why we actually have different glaucoma types. We found that ocular hypertensive eyes may actually have stiffer tissue. They may deform less if we increase IOP. And we use a lot of engineering tools to show that they may have stiffer prelaminar tissue and stiffer lamina cribrosa tissue. And again, this information might help us discriminate about the different groups. Recently, we've been looking at glaucoma eyes with a high myopia. And we found that the eyes that have glaucoma and high myopia together were the eyes that deformed the most. They were exhibiting the most amount of deformation. So we're seeing all these very, very interesting patterns in different groups, and that might tell us something. So increasing IOP is one way to do a stress test or a mechanical test to assess the robustness of your optic nerve head. But there's another way, and we can make full use of our own anatomy, I would say. We have a cable, the optic nerve, that links the eye to the brain, and we know that when we rotate our eyeball, well, that cable is actually applying a force onto the optic nerve head. And sometimes that force is so strong that even retracts the eyeball within the orbit when the eye is actually moving during eye movements, right? This is a beautiful example of this, that you really have an optic nerve traction force as you rotate your eye. We study this with model, and yes, the modeling are telling us this force can be actually quite large, about 150 millinewton, which is same order extraocular forces, extraocular muscle forces. And we confirm that using observation in vivo in patient, moving the eye in front of an OCT, that yes, we can actually see the optic nerve head, a very large shear across the optic nerve head. So the optic nerve head deforms a lot when we rotate our eye. And this is all very recent. We had very little knowledge about this before, but again, our optic nerve head is exposed to so many forces during the day and the night, and this might help us understand what is going on. So interestingly, we found that the normal tension glaucoma eyes, they were more sensitive, they will deform more in response to eye movement. This is the optic nerve head of a normal tension glaucoma eye. It's most likely to deform due to eye movement, but the optic nerve head from high tension glaucoma eyes are more likely to deform the most under an IOP increase. And again, we're starting to understand all this subtlety. So mechanics is one part that helps us understand the optic nerve head. We've done a lot of work trying to also understand the mechanics of the iris, how iris mechanics may help us understand angle closure glaucoma, and all the progression. So I'm not going to talk too much about this. This is just a parenthesis to tell you that we found some result that the iris is stiffer in angle closure glaucoma eyes and also less permeable. So biomechanics really help us not only at the back, but also at the front of the eye. So how do we exploit all this data? This is my second point on this slide. Yes, we can understand the mechanics of the optic nerve head or of the iris for that matter. But how do we make sense of it? How do we use that information to diagnose or prognose glaucoma? Well, this is really where artificial intelligence comes in, and we've done a lot of work using AI, trying to understand the structure of the optic nerve head, and we've developed techniques that can beautifully identify all tissue layers automatically, no matter what the OCT device and no matter what the noise. And we coin this technology 3D digital staining. And this allows to identify the cells, the blood vessels, the lamina cribrosa, the sclera, the collagen, everything that you want automatically. And this can be done, right now, this can be done in just a few seconds. It takes about 4 to 5 seconds to get a 3D segmentation on your computer, and can be any computer. And once you get nice segmentation, well, you can get all the parameters you want, and not just the RNFL thickness. So I just want to emphasize the reason that we're doing this is to also look deeper into the optic nerve, because we deeply believe that glaucoma is also a 3D disease. It's not just things happening at the surface, but there's also changes, there are connective tissue changes happening in the lamina cribosa, in the sclera, in the choroid, in Bruch's membrane, in RPE, and in all of these tissue layers. So it's important to bring knowledge from the depth of the optic nerve head to contribute to the diagnosis. And by using that information, we've been able to develop an algorithm that is multi-device, multi-ethnicities, that can diagnose glaucoma from a single scan of the optic nerve head. So this is one of really motivation of our work has been, can we use a single test to get the most possible robust glaucoma diagnosis? And we deeply believe that there's tons of information in an OCT scan that have yet to be exploited, and that should allow us to make a very, very robust diagnosis. So this is one of the motivation that we've been taken, and we can achieve that very accurately. Of course, it's not perfect yet, but and there is also subjectivity in your own glaucoma diagnosis, because the AI has to learn from a large amount of data. But so far, we've been able to train an algorithm, an AI algorithm, using population from Europe, Asia, USA on 5 different devices, and still get very, very good diagnosis accuracy with AUCs. We've been pushing this type of analysis a bit further, and there is actually a lot of information in an OCT scan, and it's actually too many information. So there is a huge problem, because there's noise, there's artifact in an OCT scan, and because there's too much noise, it really hampered our ability to provide the best possible diagnosis. So by using algorithm to describe the shape of an optic nerve head with just a few points, here we can maybe represent an optic nerve head with just a few thousand points. But you can imagine an OCT scan can be more than several billion of pixels. But we can actually summarize this in just a few points and much more smaller information. And once we have smaller information, we can make a better diagnosis prediction. And this is the kind of techniques we're exploring today. And the AI algorithm is able to tell you what are the most critical points to make a diagnosis. You know, we provide a lot of those points. Some of those points are from the RNFL, from the lamina, from the choroid. And this is in fast view on the right. The AI algorithm using thousands of patients. You tell us, based on these thousands of patients, these are the hotspots that the algorithm used to make a diagnosis. And this is quite interesting to me, because the first time I saw this, and we just saw this a few weeks ago, as it's not published yet, but it made me think, oh, this exactly looks like the branches of the major arteries and veins, that we have, right, at the back of the eye. So could it be that there's a lot of information from those vessels alone? And actually, we investigate this, and this is just published this month in American Journal of Ophthalmology, that we train an AI algorithm to detect glaucoma just looking at the central retinal vein and central retinal arteries, the trunk and the branches. And we found that, yes, we could provide a very robust diagnosis accuracy with an AUC of 0.9 that was higher than RNFL thickness. With RNFL thickness, we only obtained 0.75 for diagnosis accuracy. So there is information in those blood vessels. And if you look at some of those images, you know, if you have a glaucoma eye, well, the vessel, they're gonna follow the cup, right? If you have thin RNFL, if you have a really deep cup, so the vessel, they're gonna also match all those shapes. So maybe there will be value in really looking at those vessels. And we know that in glaucoma, there's nasalization of those vessels, which is also true in myopia. And I'd like also to maybe give a little provoking thought here. Could it be that also those vessels, these are tubes filled with pressure, could it be that they are protective for the nerve cells? All the nerve cells are anchored to those branches, and the nerve cells is really a jelly-like material, and you have those stiff tubes filled with pressure. Could it be that this is acting as a skeleton to protect the cells? And the only analogy I could find is this one, the octopus trying to protect its eggs. This looks like little cells, you know, and what the octopus does to protect its eggs, well, it's mapping its branches out, and we know that the legs of the octopus, well, it's a pneumatic system, so it's also filled with pressure and it's trying to protect the eggs. So could it be that all major veins and arteries are also protective of the nerve tissue? So it's just one thought that I'm throwing out here. So with AI, we try to do a bit more work, trying to understand the features of glaucoma. So this is a really nice work. These are called dimensionality reductions. This is to reduce an information of a shape of an object to just a dot that is described by just two parameters, here the x-axis and the y-axis. And then we can travel from one region to another region. And you see we have a sofa, and we go to a cup, to a chair, to a table, and we travel through that space of all these different kind of shapes. And by doing this dimensional reduction, we are learning the most important feature that describe those shapes. We have two parameters to describe the shape. And we try to do the exact same techniques with glaucoma and non-glaucoma disc, right? So on the right, on the blue points, you have the non-glaucoma eyes. And on the red, you have the glaucoma optic nerve head, right? So even in the blue region, right, you have a big spectrum, right? At the top, the nerve are very flat, but as you go to the bottom, you get a bigger cup, but they're still normal. They're still normal. And as you move from the right to the left, you see bigger cup at the top left. You see thinning, and I have a little movie for you. You know, let's say, assuming you start from the blue region and you want to go to the red region, so basically non-glaucoma to glaucoma. And on the left, this is a movie of what's happening to your optic nerve as you travel through those two regions. And you can see all the characteristics of glaucoma. You can see thinning of the RNFL in red. You get cupping, the lamina fibrosa in orange disappear. You get bending of your tissues. And you see a lot of things that we already know clinically. We know that this is happening clinically. But here, the AI was able to figure it by itself. And now we have a single parameter here, the x-axis, that lets us travel from one region to another, and might also help us predict how your glaucoma is going to change shape over time. So we're not there yet, but I think this is really how AI is going to help us. We can do this with myopia as well, and this is the nice thing. You can go from low myopia in blue to high myopia, and you see your disc, you know, expanding in myopia, right? You see your disc became much larger. And the cool thing is when you combine all of this stuff, right? And so here on my x-axis, I have from the right, I goes from low myopia to high myopia. So I'm going from no glaucoma on the right to glaucoma on the left, and on the y-axis I'm going to low myopia to high myopia, and we're really trying to understand all these islands together. So a few other things. So we can also train an AI algorithm. Knowing that we've gathered a lot of mechanics data, we can train an AI algorithm to tell you whether your optic nerve is robust or not. And we've done it. We still have to improve the technology, but basically this is the same analogy as this, right? If you're looking at a structure in 3D, you should be able to tell, right, which one is going to break first, and you know which one is not stable, right? Just by looking at it. And the same concept that we're trying to use here clinically. And since I'm over time, I'm just finishing very quickly. With just a few slides. We've been doing a lot of work on optic dysdrusen, papilledema, trying to understand all this structure for all the other optic neuropathy in 3D, because to diagnose glaucoma, it's going to be really important to also understand the morphology, the anatomy, and the biomechanics of all this other optic neuropathy that could be due from a brain tumor with papilledema, optic dysdrusen, optic neuritis. It could be even Alzheimer, Parkinson. We really need to try to understand the full spectrum of this pathology. So it's going to be critical to collect data of all this type of optic neuropathy. And we're actively trying to gather data about all these pathologies. So if some of you are interested to work with us, as to build a consortium to look at all the potential optic neuropathy, because by knowing all about this optic neuropathy is going to help us better diagnose glaucoma in the end. So I would like to thank, of course, all the people that contribute to this work, all the people in Singapore, and my sources of funding. There's a lot of more people that I didn't list, I'm sure, but the main people are here. And I also would like to thank all the engineers that work in my lab, because these are the really smart brains that have developed all these techniques. You know, I'm just here to orchestrate everything. I'm not doing the work. You know, I'm just making sure they're developing the algorithms and managing them and making sure that they can publish their work. So I thank them a lot as well. And to finish, this is my email address at the top. Feel free to email me if you have any questions. And this is also my slide summary of the lab that we do all about developing engineering tools for glaucoma and other ophthalmic disease. Thank you very much.
So thank you, Dr. Girard, for such a wonderful talk. So Dr. Raju?
So yeah, Dr. Girard, thanks a lot. You know, it was a really fascinating work you presented here. And I'm sure there would be some questions, but we'll finish Gauri's talk before we take the questions. So I request Dr. Gauri to give her talk, and she'll be talking about the various facets of IOP. Dr. Gauri, please take over.
Yeah. Can you see my screen? Can you see my screen now?
No, Dr. Gauri, not yet.
Now can you see it?
You have to just maximize it. Yes, it's visible.
Yeah, I have maximized it. I think there's a slight lag period. So I think it should come by now. Is that okay?
No.
1 second, I will maximize it again. Now?
Yes.
Yeah, okay. So I'm going to talk about the various aspects of IOP in glaucoma management. So the association between intraocular pressure, raised intraocular pressure and glaucoma was described way back in the 10th century by Arabic physicians. And later on in the 1600s, Dr. Richard Bannister, he actually associated this raised IOP and associated with a disease called glaucoma in this treatise of 113 diseases that was published at that time. Subsequently,
Dr. Gauri, sorry to interrupt you, but I think that is not in that slideshow mode.
Okay.
So you can just redo it, yes.
Yeah, I will do it once more. Yeah, is that fine, Shefali?
It's not Anmol. He's from our backend team. Mr.
Yeah.
Anmol?
Ma'am, not yet. Ma'am, can you reshare?
Yeah, can you guide Dr. Gauri, please?
Yeah, I'll just connect. I'll just stop share and share it again.
Yeah,
so
please.
that it comes
Yes,
again. Okay,
yes.
I'm so sorry about this.
Ma'am, PPT is visible. Can you put it on the slideshow mode?
Yeah, Dr. Gauri. Yes, fine now. Is it fine, Anmol?
No, ma'am, it has again exited.
Again it is, yes. Now it's fine, Dr. Gauri.
Yeah, okay, fine. So I'll go on. There's something which is happening over here. Okay, so later on, we have come to realize that the intraocular pressure is just a risk factor for the development of glaucoma, but we all realize that it is the only treatable parameter. So the only accurate way of measurement of intraocular pressure is cannulation with manometry. And all other ways that we employ are indirect, and have limitations. We employ indentation, applanation, and contour matching. Each of these have their advantages and disadvantages, but by and large, we tend to use this applanation tonometry as the gold standard in our clinic. So we know that applanation tonometry has a lot of limitations. The corneal thickness and the biomechanics of the cornea lead to errors in recording of the intraocular pressure. It is a established knowledge that thick cornea leads to overestimation and thin cornea leads to underestimation. So various so-called nomograms have been developed, and there is this concept of converted or corrected IOP. I should stress here that validation of nomograms remains problematic, and rather than correcting for the corneal thickness, one needs to look at corneal thickness more as an independent risk factor for development of glaucoma and its progression. So categorizing the eyes into thin, thick, and normal thickness corneas are more useful than looking at corrected intraocular pressures. We also should realize that the IOP measurement that we take is just a sample of the whole. IOP varies during the day and night and between days. And as we know, supine and nocturnal intraocular pressures are generally higher than waking and sitting intraocular pressures. There are various other factors which influence intraocular pressure, including body position, head positions, blinks, eye rubbing, caffeine, medication, hormones, BP, yoga, wind instruments, the list goes on and on. So there is this search for a continuous IOP measurement device which can give us the entire pattern and not just a single snapshot that we take in the clinic. In this regard, the sensimate triggerfish lens, which is a contact lens sensor, has been used to monitor the intraocular pressure over a prolonged period of time. Here, it's not the intraocular pressure per se in millimeters of mercury which is checked, but the variations in the eye pressure can be detected. So is this something that we can use? Is it an accurate measure of intraocular pressure? There are varying publications which have been published, but I'll just show you this publication by Praveen Vitish Sharma et al. So there is this study where they did this on patients who were undergoing general anesthesia. They put the lens on one eye and the other eye, they measured the tonopin IOP. You can see in the first patient, the curves are more or less similar, both the IOP in millimeters of mercury and the lens data. But in the 19th patient, they are vastly different. So there are variations and you cannot really substitute one for the other. The search went on and now there are implantable sensors, and these sensors are put inside the eye during cataract surgery, either in the ciliary sulcus or in the suprachoroidal space. These are also promising devices because these have more accurate measurement of intraocular pressure than the extraocular measurement devices. Let's go through a few facts. Single in-office IOP measurements are unlikely to capture either the IOP peak or the trough. So when you measure a single IOP in the clinic, one should realize that you may miss up to 62% of the intraocular pressure peaks and 88% of the troughs. So don't take that single IOP reading at face value and have a lot of inferences from that. So what is normal intraocular pressure? The intraocular pressure approximates a Gaussian distribution, but has an exaggerated central peak and a modest skew to the right. And the mean is considered as about 15 millimeters of mercury, and 2 standard deviations on either side are considered as normal in inverted commas. But not all eyes with raised pressures develop glaucoma, and the converse, not all eyes with low pressure do not have glaucoma. So you can see that there is a trend of the incidence of glaucoma to go up as the intraocular pressure goes up, but the incidence of glaucoma is there even at so-called low and normal intraocular pressures. So taking this further, if you look at the curve of normals and the curve of patients with glaucoma, you can see that the IOP frequency distribution curves overlap. And if you take this right part, this is magnified over here. you can see that the intraocular pressure is higher in eyes with glaucoma, but there are many normal patients with high intraocular pressures as well. So the probability of glaucoma increases with raised pressure, but is not absent at low intraocular pressure. So let us look at other measurement aspects and their clinical significance. What do we give importance to? Do we give importance to the peak IOP, the mean IOP, or to the IOP fluctuation? Generally, it is the peak IOP that we use to make clinical decisions. And mostly in clinical trials, it is the mean intraocular pressure which is used. Let's look at IOP fluctuation. IOP fluctuation can be instantaneous during a blink or, for example, eye rubbing. It can be a short-term fluctuation, which is in a period of 24 hours or less. This can be a circadian or diurnal nocturnal variation. And you can see that in this curve, you can see that the intraocular pressure varies between diurnal, sleep, and early morning pressures. And it varies between supine and sitting positions. Long-term intraocular pressure fluctuation is a fluctuation in a stated time period understood to be on separate days. So IOP is also known to vary according to seasons and from month to month and year to year. Few other facts: fluctuation of intraocular pressure is larger in some subsets of glaucoma, including pseudoexfoliation, angle closure glaucoma, and pigment dispersion syndrome. So is fluctuation actually associated with the risk of progression? There is no evidence that intraocular pressure fluctuation is associated with progression in the OATS, EMGT, early glaucoma prevention study, and the OHT and DIG study. In these situations, all have higher IOP, earlier glaucoma damage, and modest to no treatment. That is common to all these clinical trials. But according to the AGES publication, long-term fluctuation of IOP is a stronger predictor of progression compared to mean IOP. And they also mentioned that fluctuation may be more important in patients who are starting off with lower levels of intraocular pressure. Another study called Japanese Archive of Multicentral Databases in Glaucoma looked at the evaluation of glaucoma progression in large-scale clinical data, and they found that average IOP was not related to progression rate, but fluctuation was. It was associated with faster progression. And they said this was not the case when the IOP was below 15 millimeters of mercury. So there is some conflicting literature over here. Let's look at the intraocular pressure reduction in the management of glaucoma. Generally, the motto is lower is better. Across all RCTs, lowering of IOP by at least 18% results in 40% or greater reduction in glaucoma progression over a 5-year time period. In the early glaucomas, the IOPs are consistently less than 17. They found no progression. In advanced glaucomas, less than 15 millimeters reduce progression to almost 2/3 of patients. So it depends on the extent of damage as well. Also, glaucoma filtering surgery has a better 24-hour IOP reduction and has smaller fluctuations compared to maximal medical treatment, including the prostaglandin analogs. One should remember that lowering intraocular pressure does not guarantee stability of the visual fields or the optic nerve head. You can see here from a publication from the Moreflow study group that there is overlap between the IOP ranges of those patients who progressed and those patients who did not progress. So one cannot say that lowering IOP can guarantee the stability of the visual field. The other concept that we always use or tend to use is the concept of target intraocular pressure. European Glaucoma Society, AO and WGA define this differently, but clinically it is a range or a number that we set as a target for us to bring the intraocular pressure down to. And at that range, we hope that the visual fields and optic nerve head remain stable and do not progress. So is this target IOP a threshold IOP, rather a single number? If you look at the AGs, they say that the advanced glaucomas, generally if the intraocular pressure is less than 12 millimeters of mercury, you can expect the visual fields to be stable. But one should remember This is from a post hoc analysis of the AG's data. And the concept of threshold IOP itself is not evidence-based. If the study had been randomized according to target IOP, that is a subset having less than 12 millimeters and a subset having greater than 12 millimeters, and this randomization was done according to this criterion, then probably the AGs would have been more confident in making this conclusions. And we also know that not all non-progressing patients had an IOP of less than 12.3 millimeters of mercury. So is this a percentage reduction? Generally, we say about 20 to 40% reduction is what we need to aim for. This has been used in OATS, the EMGT, and the CNTGS studies. And in the clinical situation, we use this percentage as a dependent parameter on the presentation, the age, the family history, life expectancy, and the presence of pseudoexfoliation. There are other formulas as well to calculate intraocular pressure, target pressure, but these are also largely in the theoretical domain and not in the clinical domain. So what we need to remember is target IOP is a guess and it is not a perfect measure or a percentage. In short, I'd like to give you these take-home messages. IOP measured is not true IOP, and we measure just a snapshot. One should realize the limitations of office IOP measurements to capture fluctuations of IOP, and surrogates such as supine IOP or IOP following water drinking may also provide an indication of the range of IOP fluctuation. So there is a case to incorporate these in our clinical examination. The risk of glaucoma increases with increasing intraocular pressure. Lowering intraocular pressure prevents progression but does not eliminate it. And IOP fluctuation may be more important in patients with lower presenting intraocular pressure. And finally, continuous monitoring may be a game changer in the future. Thank you so much.
Thank you, Dr. Gauri. It was indeed very informative talk. And
thank you.
Yeah, so I think now we are open for panel discussion. And I have prepared few questions for Dr. Girard. So I'll just share my slide.
Visible.
Yes, yeah. Is it visible?
Yes.
Yes.
Yeah. One second, my panel, I am not able to see. One second. So, Dr. Girard, so do you think now at this point of time, what we are mainly relying for the diagnosis of glaucoma is basically your clinical examination and structural and functional test. But now, since AI is in the picture, so do you think that the AI will improve the diagnostic capability of for diagnosis of glaucoma? And considering that there is a wide variability in the optic disc size, so do you think it will be difficult to have this AI that with this variation to improve the to have more better diagnostic accuracy?
Yes. So the short answer that I would say is yes, for sure. AI is here to stay, and it will come to the clinic to improve the diagnostic capability of glaucoma. So that's a short answer. But the longer answer is that it's actually not that easy to get there to have a really robust glaucoma diagnosis. Because I mean, if you look at the literature, I mean, most study in the literature. Sorry, most of the literature, when they do glaucoma study, it's always glaucoma versus healthy, right? Which is, and you know, like 90% of AI studies, glaucoma versus healthy, glaucoma versus healthy. And so we're completely ignoring that, well, in your clinic, you know, it's not just two groups, right? You have a full spectrum of people. And like I mentioned, you have all these optic neuropathies, you have myopia in the middle of the equation. So, and to be able for AI to pick up all this different kind, well, we need a massive data set. So I think for AI to become useful, we need to have some international consortium where people really unite to share data of all the potential pathologies affecting the optic nerve, and then train an AI on a really, really vast amount of data. We cannot just train an AI algorithm in a paper on glaucoma versus healthy and expect it to work in the clinic. This is not going to be so simple. So my longer answer is like, yes, it's going to be useful and for diagnosis ability, but it's going to take a bit more time. And the second point I want to make, it also, glaucoma most likely involve a lot of physical phenomena that we may not fully comprehend, right? If it has to do with blood flow, yes, with biomechanics, or with axonal transport, molecular movement, cell behavior. We don't even have the tools or the imaging equipment to comprehend that type of information. So we are still missing equipment, hardware to map this information beautifully. So for sure, AI will help, but will not be able to do that 100%.
Yeah. So my next question to you is, will AI help in picking up the early progression? Do we have any data regarding that?
So, I mean, this is very tricky to prove in humans, but there is some evidence in animals that before there is any functional loss, and this is some of the work I've been involved with in the lab of Claude Burgoyne, which I did my PhD with Claude Burgoyne a long time ago in Portland, Oregon. And so there is some evidence in the monkey model of glaucoma that connective tissue changes precede neural tissue changes. So there is some evidence to say that there could be change in the sclera, there could be changes in the choroid or the Brooks membrane, or even the lamina cribrosa that might even precede the first sign of axonal death. So if that is the case, then yes, AI should be able to pick it up. And this is one way where AI will be able to pick it up, because if we can map those changes, not just RNFL, and again, my point is glaucoma shouldn't just be limited to RNFL thickness or visual field testing, right? We really need to come up with new technologies, new hardware to probe the rest of the disc. So again, the answer is yes, but there's still a lot of work to get there, I believe.
Yes, I agree. There is a lot of work to do. It's initial phases that we are. Slide is not changing. So I think, Rajul, can you take over? My slide is not changing here.
Okay. So you just share again. Till then, there are some questions from the audience. I'll ask Dr. Yeah. So Dr. Girard, that one question is the the diagnostic accuracy. So do we have any cutoff for the OCT or imaging that you would like? Do you use for the data collection?
Sorry, I didn't catch the question. Could you repeat?
The imaging quality impact the diagnostic accuracy of the algorithm, just like the normal. Shifal, just stop sharing now for timing.
Okay.
So
okay.
I can ask the questions.
So you're asking
the imaging quality of the OCT.
Yep.
Does it have any impact on the algorithms, the success rate, diagnostic accuracy?
So yes, it's a very, very, very important question, because in the clinic, most of the time, it's very, very busy clinic. So the image that you get in clinic may be completely different than the data that are actually shown in publications, right? And so that's a very important point. So I wasn't able to show here today, but we've done a lot of work on AI to improve image quality. So to improve the deep tissue visibility, but also remove the noise and also remove artifact. So my group has done a lot of work on this, and I'm not the only one, right? There's a lot of researchers that have been working on this, a lot of groups in China, in the US, in India, that have been doing this kind of work where, you know, if you learn from a lot of data set, you know, noisy image and clean images, well, you can learn, you know, a denoising type of functions. So the good news is, so I'm more confident to tell you that the image quality may not matter that much. We can always restore them, but the danger is always to make sure we restore something that is true and it has to be validated, right? So if you want to get approved by the FDA or CE marking or the equivalent of the FDA in India, you will need to validate that your algorithm does not create additional artifacts, right? So that's one of the great danger with AI, you know, to make sure that or self-driving car, right? You know, it doesn't just drive and fall off a cliff because it was not taken into account in the initial algorithm. But from my initial understanding, we have the tools to make really, really beautiful images. And now also people are working in AI algorithm to be part of the OCT machine. So this is also a very active area of research. So because now you're doing very complex raster scan or diagonal scan in your machine, and we can maximize the speed or the scan pattern, you know, we can do this imaging much smarter, maybe in milliseconds, and that AI can really help you also understand the physics and the optics of the eye to try to optimize the imaging. So there's a lot of research that is being done to optimize the hardware today with AI. And even if the hardware provide noisy data, we have a lot of algorithms to denoise the signal and bring back the signal to life. So this shouldn't be too much of a worry, but again, validation is going to be the key.
So I think you partly answered the second question, because the second question was that the pixel changes in the photo do changes the algorithm's accuracy. I think you already mentioned that.
Yes,
you can manipulate and improve the quality of images.
Yes.
Am I right?
Yes. So you're saying actually, so in the pixel itself, there is an optic property called reflectivity. So that information itself, we may be able to diagnose glaucoma because this might relate to the organization of the fibers, either the nerve fiber layer or the collagen fibers. So there is optic information with this pixel value that is also exploited by the AI algorithm. But again, this also can be filtered and homogenized, I would say, so that there's tricks to homogenize and restore back the signal. So this shouldn't be too big of a worry.
So the third question was that most of the data what we have at this point in time is with the small homogeneous group. We have not tested into a different heterogeneous group. So do you think that we'll be able to work out to a common formula across because the racial, the discrimination in the optic is the differences is quite huge. So do you think that we have to have a different algorithm for the different population, or we'll be able to work out one algorithm which works across the universe?
Yeah. So the holy grail will really be to have one algorithm for all eye disease. That'll be and I think we're gonna get there eventually. It will be one algorithm, one machine, and for all disease. But let's start simple, right? Let's start a bit simple. If we could already have one tool for glaucoma and other optic neuropathies, because some optic neuropathy may look like glaucoma, right? And if we could have a tool that be really, really robust for glaucoma, and including all the other things like myopia, you know, can we really tell this is high myopia plus glaucoma or is just high myopia? You know, just this kind of problems would be really, really useful clinically. And but we need the data. So we've set up a few consortium in Singapore. So one was called Octagon for glaucoma specifically. We have other consortium that we're building now for other optic neuropathies. But I feel it needs to be international efforts where we merge data from multiple countries. we merge data from multiple devices as well. This is what we've done in one study. We've put 5 devices, and this is also quite important. How do we go from one device to another? Like we have the mapping function, so if we have an OCT scan taken from a spectralis, we can put it back into a Cirrus type of format, or the way it will look like in a Cirrus. So we can do this mapping, but it has to be an international effort that people will share data. And if some of you are interested in contributing to those studies, we have a lot of engineers in Singapore, and that we could work with you guys to expand the reach, because we really need an international effort from multiple countries to get there.
Yeah. Thanks. I think Dr. Shefali, can you take over?
So
for Dr. Michael. Yes.
Yeah, so I think that was very informative, Dr. Girard, and I hope you will stay with us. There are questions for other panelists also, and I'm sure you are going to enjoy our discussion.
Yeah, so if the other panelists want to have any comments about the AI and ask any questions to Michael before Shefali start asking to other panelists.
Yes, sir. I have a question for Dr. Girard. Can I go ahead?
Yes.
Yeah, please, you go. Yes.
Yeah, Dr. Girard, indeed, it was a very nice talk today. One thing there is in my mind that in OCT, usually we don't rely for the myopic patient. But what I inferred from your talk today was that the AI is going to help us in differentiating that the patient is having only high myopia or high myopia along with glaucoma, which is not able to be deciphered today as a single isolated findings, what we are seeing in our OCT, right? Am I correct?
Yes, correct. So today it's really hard to know whether this is high myopia plus another condition, high myopia plus glaucoma, high myopia plus something else, or it's just glaucoma, right? And some people, some myopic patients get trabeculectomy when they don't really need them, because it's another kind of visual field detect that they get. So AI will help us solve these kind of subtleties that are very difficult for us to understand, because it's for a human, it's really hard to understand a 3D shape. It's really difficult to interpret a 3D shape. We are really good to see a curve. A curve makes sense, but when it starts to get in 3D, and in the clinic, you guys don't have time, right? You don't have time to look at the things in 3D and rotate it. You don't have time to do that. And maybe we could train humans to do it, but this is just way too complicated. So the AI will be able to pick up those signatures, I would say. I like to call them, what are the optic nerve head mechanical or structural signature that are for different subgroups, and the AI will be really good at picking this, like we've shown in some of example in my talk. But again, there's still a lot of work to do. We still need to collect a lot of data, and this is just a start. So I mean, we still have work to do for the next 10-20 years for sure before a really AI really come to the clinic. So it's not yet here for today. So.
Okay. And does AI compensates for the physiological cupping also? Because in some of the cases, glaucoma is misdiagnosed because the physiological cupping is supposedly diagnosed as glaucoma. So is AI going to give us some clue regarding that also?
Yes. I mean, so what I hope that AI will also be able to do to help us with, it's like maybe providing another definition or a better definition of glaucoma, whether it's structural, whether it's mechanical, whether from it's a blood flow point of view, whether it's physics, whether it's cell, whether it's molecular, whether it's genetics, whether it's a mix of everything and interaction with all things. I'm hoping AI is going to get feature of, it was going to be really good at identifying the features that we cannot necessarily identify or parameterize on our own that easily. So this is where really AI is going to shine. And we've shown that, yes, it's good at picking features that we already know. So that's a good start, right? So AI is picking features that we already know about them. But then let's try to train it to identify feature we didn't know about, and this is really where AI is going to be is going to help us redefine glaucoma, I would say.
So thank you. I'm done. Sir, we can move ahead.
So I think any other
Dr.
questions
Shefali,
from
why
other
don't you
panel?
start?
Yeah. So Dr. Gauri, I would like to ask you on intraocular pressure, since you had discussed about the different aspects of intraocular pressure. So which aspect, whether it is a peak or the fluctuation in IOP or the mean IOP, which one do you give importance in your practice?
Practically, when we are in the clinic, we initially base our decision making on the peak intraocular pressure. But I think as we collect data over different points of time, we should factor fluctuation in. Mean intraocular pressure, I don't think it has a role in the clinical setting, but more in terms of clinical trials or in a research setting, you may have to look at mean intraocular pressure. I would look at the peak initially and try to obtain a range of intraocular pressure values, not base my clinical decision on only a single intraocular pressure value. And also, I didn't mention that explicitly in my talk, to label a patient as normal tension or low tension glaucoma in the beginning itself may not be a wise thing to do. So as you go along, you will see that the pressure might fluctuate and this patient might actually be a patient with primary open angle glaucoma. So initially it is the peak and later on you factor in the fluctuation.
So basically, once we have started the treatment, then we have to see whether there is no fluctuation or there has to be minimal fluctuation, so that to avoid the progression. So since you are talking of the fluctuation in intraocular pressure, my next question to Dr. Ganesh, do you regularly do diurnal variation test? Or if you are doing in particular few patients, select patients, then what is that select group of patients where you do DVT and how do you do that DVT?
So thank you for the invitation. Nice to be part of the program. We do DVT, but as of now, because of Corona, we have stopped it. But before Corona, we used to do DVT for patients who would present with high normal pressures, something around 18, 19 with very distinct features of optic nerve head pathology. We feel that, this is related to the fluctuations which will maybe elicit by doing DVT. So we have the facility of patients getting admitted in a hospital, and we do DVT from whatever time they get admitted to about 1-2 hours before that. So the next following day. So suppose they get admitted at 10 o'clock, we still do it till 8 o'clock the next day morning. We don't do it after 10 o'clock. We start from early morning 6 again. So we have that facility. Of course, office DVT is also possible, but we have been doing diurnal fluctuations in this manner. And these are patients even patients who progress apparently having a very normal intraocular pressure. Even then also we subjected from DVT, and we have also subjected patients who are on medical treatment. They can be on treatment and then also they can undergo DVT.
So any other opinion, like since Dr. Ganesh is in institute, for him that facility is fine that to go at 6 o'clock, but any other opinion to do whether you are doing office hours pressure checkup?
Yes, ma'am. We do office hours only, ma'am, because it's not very much possible for us, though we are in a hospital, but the patients, they come from far periphery. So it's like very difficult for us to counsel them that they need to stay back in the hospital for the DVT. So we do in office hours only.
Yeah, so basically at different times of the day. Yes, Dr. Prashant, you have to say something.
So I'd pretty much done a lot of this office diurnal office hour DVTs, and at some point I tried to fool around with the eye care, the home eye cares, and in concept it looks nice, but I think that only when I try to do it myself, I figured that it's pretty difficult to expect a patient to be able to do that home eye care. Ideally, the actual eye care is fine, but the home eye care device itself is so unpredictable, so that even though it as a concept it looks interesting to do, how close you actually hold the tonometer, and there's so much of variables. I don't know if the others in the group have that same experience, but over the years I have it sitting next to my desk, but I haven't used it in the last couple of years, I think.
I think the home eye care is, something very close to the basic eye care. I see, I think 100 or something like the basic model. So it really depends on the operator, how they do it. So it has to be kept vertical. The other advanced versions have the alignment or the green light, which shows that, you are at the correct point away from the cornea and you are vertically the machine is vertical and you can go ahead and shoot. And so many parameters are built into it. The basic one and the home eye care, they don't have that. So that's why people find it difficult using the home eye care. In fact, one of the inquiries was that whether I could buy the home eye care. It's about 2.5 lakh rupees, and I didn't know what to tell the patient. So some sort of dilemmas do come in when you.
Can we ask Dr. Girard if they must have used the intraocular pressure sensors, both the trigger fish and the implantable sensors? Have they really made a difference? I mean, with the big data and artificial intelligence, have they been able to incorporate these things in the monitoring for progression and other aspects of the patient with glaucoma?
I think in Singapore, I think Mani Bhaskaran was working on a project with a triggerfish. I don't know if he's here today, but maybe he could comment. But I think he did a study on this, but this has not been fully implemented in Singapore. This has not been fully implemented, and I mean, this is also tricky, right? Because the triggerfish, if I understand things well, the triggerfish, it only look at the change in curvature of the cornea, right? You've explained it, and of course it will also depend on the mechanics of the cornea, and so it's like from a physics point of view, it's an ill-posed problem. We have two unknowns. The unknown is the stiffness of the cornea and the IOP inside the eye, and we're trying to measure one thing, but we actually have two things we don't know. So it's a very difficult engineering problem. Actually, it's a very, very difficult engineering problem. So the guy that comes up with a way of measuring IOP accurately will be a billionaire, I think, today, but we're still very far from it. And that's why, I mean, that's why you showed it very nicely, that you have this, some patient it match, other patient that doesn't match, and it's really hard to know what is going on there. It's really hard. So, but I don't think it's been implemented more than just a few studies in Singapore.
So I think we are talking of biomechanics of cornea. So my next question is, in post-LASIK, what is the best way to check intraocular pressure? And in case if that best way is not available with us, then what to do? So I think it is open. I think Dr. Sushmita, would you like to answer?
Thanks for having me, Dr. Michael. That was a fascinating lecture. Thank you for opening our eyes to the possibilities which we could look forward to. So I'd like to ask you this as well. So when we worked on the ORA with the biomechanics, we started off with the premise, and that's what the company sort of promised, that the corneal biomechanics is independent of the intraocular pressure. So you could do the hysteresis, and it was thought that one of the reasons for people having glaucoma as well as progressing is that the hysteresis is higher and the laminar compliance would be more, and like you showed the trampoline, so they would trampoline more and the optic nerve fibers would be damaged. So interestingly, we did find that people with higher pressures did have a lower hysteresis, whereas the lower ones had better hysteresis. But then the interesting thing was, when we lowered the pressure after surgery, and it was just it was a curiosity for us that what happened. And once we lowered the pressure, the hysteresis pretty much went back to the normal ranges. So we realized that the hysteresis, at least that the ORA is measuring, is not intraocular pressure dependent at all. So those who have high pressures in any case have low hysteresis. And when we brought down their pressure, so we thought it was something to do with surgery. So we gave them Diamox. We said, okay, let's not fiddle with anything. We'll just systemically give them Diamox and do a pre and post, and that was easier. And again, when the pressures came down, the low hysteresis actually reverted back to normal. But the caveat in that was the normal tension glaucomas also had a lower hysteresis than the normals. And the ocular hypertensives had a better hysteresis. So there's something there, but I don't think the ORA has answered that question. And what would be your take on it?
Yeah, yes. So I'm a bit, I have contradictory, different thoughts on the ORA, because on the one hand, it measures something at the front of the eye, which is far from the site of damage. So from a mechanical point of view, it does make sense. From a first mechanical point of view, the optic nerve head and the cornea, they're exposed to the same pressure. So it will make sense that they kind of reflect similar, collagen behavior or sliding behavior or molecular movement. But at the same time, at the back of the eye, you also have the weak spot, which is your optic nerve area. You have the lamina cribrosa. So the stress, the forces are much higher at the back than at the front, because you have this change in material properties at the back that you don't you have it at the front as well, but it's a boundary between the sclera and the cornea. But at the back, you're going from something stiff, the sclera, to something really, really, really soft, the lamina and the axonal material. So the balance of forces is not exactly the same between the front and the back. So yes, the front can help us learn something about the back, but it cannot be the only thing. So what I will say, what we should encourage, try to do, is to have an hysteresis test for the back of the eye, for the posterior pole. And the only reason we haven't done it so far is because it's really challenging, because you need to be able to image the back of the eye really fast and with a control load. At the front, it's very easy. You send an air puff, and that's why it's very easy. But we will need some sort of hysteresis test for the back of the eye. And I think this will help us understand more of those relationships. But another problem that I have also with the ORA is that when you do an air puff, some eyeballs are retracted within the orbit, and some eyeballs are retracted more or less within the orbit. So there's some padding, the orbital fat that we have behind the eye, and that orbital fat is also viscoelastic. There's also water movement. There's also friction. So there's also viscoelastic properties. So the measurement of the ORA may also be conflicted with what's happening in the orbital fat. So again, this is, so we're not 100% sure today that the measurement of the ORA is 100% from the cornea and not other tissue around. I mean, it's useful, right? Like you said, you're seeing these trends in the clinic that might help the patient. But again, we don't fully understand the physics completely. And I cannot tell you today what the physics means exactly. But I think we need to keep developing those devices and making sure we try to make one for the back of the eye as well.
Yeah, I agree. So I think ORA and DCT, they are not available with everyone. So ideally what we should do, if the patient have old records, I think that is the best way to go ahead. And we should ask, in fact, every patient to keep the old record before, or whosoever are doing the LASIK, they should give those records to the patient. So I think, Dr. Rajul, would you like to take over, or I have few questions for other panelists?
Ask a couple of questions, then I will one or two cases.
So now,
yes, Sachin.
Sachin, yeah. So I would like to ask about the provocative test. So do you
that point about post-refractive surgery?
Yeah.
Only one point here for those who are listening. All of us usually know it, but especially if it is post-LASIK, then we have to be always careful about the interface fluid that may develop in conditions of high pressure, which may again affect the IOP measurements. You may get false IOP measurements or maybe slightly on the lower side, but this is something that we have to be careful of. So in those cases, definitely what will help us is the trend of intraocular pressure, as you rightly said. So if we find there is some disruption in that trend, then definitely we should always keep the interface fluid in mind.
Yes, interface fluid and post-steroid effect also that we have to keep in mind. And DCT takes out the effect of that corneal biomechanics. So I think these are the options. But anyway, like everyone cannot have DCT and ORA. So I think what we should do is we should compare with the previous intraocular pressures, and we should keep the record of number of multiple readings. So now, Dr. Sachin, would you like, this is regarding the provocative test. So are you in favor of doing the provocative test for angle closure glaucoma and open angle glaucoma? And which one?
Angle closure glaucoma, usually I do not do. the dark room and the prone and all those things a bit.
Mid-dilated intraocular pressure checkup may
But
help.
as I think Dr. Gauri also rightly pointed out in her talk, that it does give us an additional bit of data if you do a water drinking test about the ranges of IOP fluctuation that you can have. Maybe you are actually challenging the outflow facility of the eye by introducing a lot of fluid overload. So the kind of behavior of the dissipation of high intraocular pressure post fluid overload can just give us an additional bit of information. Although many studies, I mean, it's been done, as you know, only by one person internationally, most of the water drinking test studies. And the other groups who have done it, maybe I think a group in Shankar Nitral, if I'm not mistaken, has tried to look at that, and there is no conclusive evidence as such. But definitely, I have seen some people spiking quite nastily to around mid 30s and mid 40s post water drinking test. So that will just add a nugget of information as far as their outflow facility and in terms of the management, we may be slightly keep it at the back of our mind and be slightly aggressive. But scientifically, I don't think we have any information to give any recommendations based solely on the basis of water drinking test.
The only thing is we can advise patients who have glaucoma to avoid drinking water in the morning. Like a lot of patients have that habit of drinking 1 liter of water in the morning. So I think that at this point of time, that is what we can do. And
it's also just as on a similar note, there you will have an occasional patient who comes to you after having to go to radiology for getting an ultrasound done, and typically that's also when they do have the informal water drinking test of loading the bladder, and then having an off-style appointment. If you're in a multi-central hospital, it happens quite often when they double book. I mean, when they book the appointments back to back, and it's not surprising to actually see glaucoma patients spiking when they've just had just a water overload just for a bladder, or just for ultrasound.
Yes, Dr. Prashant. So, Dr. Parul, are you here?
Yes, very much here.
Yeah, so it's just one clinical simple question. Like you have patient advanced glaucoma 0.9 bipolar notch, and you do corneal thickness. Like we have two scenarios. One is very thick cornea, 600 microns, and another scenario is thin cornea, say less than 500, say 475 microns. So, and you have patient with advanced glaucoma bipolar notch. So how would you proceed? Giving both the scenarios.
Well, once the damage is so advanced, I think the only way to go is be aggressive and to bring down the pressures as much as possible. So keeping the range of about 10 to 12 as my target, I would just, irrespective of the corneal thickness, just push the pedal to the most and bring down the pressures.
So agreed. So basically the damage is there, so whether it is a thick cornea or thin cornea, you have to just keep in mind when it is thin cornea, yes, you have to be more aggressive. I don't think we have to use the nomograms. So that any other opinion from the panel, or everyone agrees here? So my next question is, so what progression software you use? Maybe Dr. Shweta or Dr. Prashant, anybody who wants to answer. So which progression software would you prefer, and whether you go for clinical progression, like if you see the optic disc, so would you, if you see the progression on the disc versus if you see the progression on OCT, which one would you give more importance?
It depends on, ma'am, can I answer that question?
Yes, Dr. Shweta, yes, please go ahead.
So first of all, I would like to thank you and sir for making me a part of this academic feast. So coming back to the question again, so if first of all, that I prefer doing an overview and a GPA for monitoring the progression in my cases. And secondly, if I see a progression on the disc and the OCT, if the OCT, the signal strength is strong enough and there is no other criteria which is making that OCT unreliable, I would like to go with the OCT as well.
So basically you are going to incorporate both. See, field, definitely field progression is there. I am just keeping the field progression out of this. If you see progression on the disc, clinical progression, or if you see on OCT. So basically, which one would you give more importance, clinical progression or on OCT?
Ma'am, I would correlate both the things together.
Yeah, I agree. So any other opinion from the panel?
I'll ask Sushmita. Are you there or you left?
Yeah.
So since you've done some work on OCT, the series is lots of different parameters. So I'll just take one question, from the progression from Shefali. We have event-based analysis and we have trend-based analysis. So 3 different parameters we have on OCT. Do you give any specific weightage to any parameters?
No, I would just look at the global trend, which the OCT shows, but also look very carefully at signal strength. The most important cause of progression on the OCT, which I found out, is difference in signal strengths between the two examinations. So if you have a signal strength of 9 on one and 6 on the other, you just might have progression, so you don't look at that. So the OCT, to me, is also has its own set of problems, and the signal strength could be affected by things like a dry eye, cataract, refractive error not being all right, so all sorts of things. But given that, if everything else is fine, I would look at change. But Rajul, I would be very wary of changing too much if the function is absolutely normal. So if the function is absolutely stable, yes, my criteria for progression would be very much more a function rather than structure, unless it's very early and the visual fields are near normal.
Or if your target pressures is not achieved anyway, and it shows structural changes, then you would,
then I would still get the pressures down, all right, but I would still repeat the visual fields again to be sure that functionally it's all right. But early glaucomas, OHTs, I would do structure, yes.
Shmita, what sort of, in your population, sorry, may I ask a question?
Yeah, please.
Yeah, sure, Prashant.
So Shmita, in your population, what sort of disc areas do you start getting suspicious? About what number of a disc area do you start getting suspicious in an Indian population? I don't know if there's a difference between North and South India, but is there any number at which you start looking at your OCT more suspiciously or don't give it as much importance? I'm talking about large disc and small disc, but in an OCT numbered way.
I would be very wary of small discs, and I would look, whenever I see white on the OCT, I'm very, very scared. Because if there is a white on the OCT, then it's crowded and it's on the higher side of the normative database. And we are very, very likely to miss, because the machine is going to miss a significant progression, quote unquote, because the machine doesn't know that for this particular optic nerve. So I would be less concerned of large discs, which are usually overdiagnosed as glaucoma, but I would be very wary of the smaller ones. And if you give me a cutoff for Indian eyes, anything more than about 1.7, 1.8 is a bit of an all right thing for me, because but anything less than about 1.4, 1.3, I would start getting very wary. And I insist on disc sizes for every new patient that comes in, because that's the most important thing.
Okay.
So yes, Sajin.
Yeah, the important thing that listeners should know basically is that the usage of OCT for progression has to be a very disciplined affair. There are 2-3 things. One is that all the OCT machines do not have the capability of superimposing scans for progression. So people doing scans, for people who are technicians, most of the time, if they are changing and they are untrained, then they are not going to be the ideal candidates, number one. Number two, the machines have to be an absolute standard where they have a torsional and a rotational, rather a rotational and translational alignment of scans to the subsequent scan, which is very, very important. As the machines, the series you're talking about, the R2 and in Spectralis, obviously you do already have the alignment FODI in place. So if with those scans, if you have the same signal strength on every scan, superimposed images on every scan, and you check the segmentation yourself on the machine, then there is all the reason to use OCT for progression. I'm not saying that go for the overkill, but what people don't realize when they talk about progression on the OCT is about the right machine, the right technique, and the right person doing the scans. Because if all these three things are not followed, then it can be a very dangerous tool which can lead to a overkill in terms of medical treatment.
Yeah, I would just add one more thing, Sachin, that not only for progression, for diagnosis also.
Yeah, absolutely, absolutely.
So the
and
imaging
progression,
is
the only advantage what these machines would give you is that even if these patients, like what Dr. Prashant and Sushmita madam said, that if they are outside the normative database of the machine, if the machines are that good, then the longitudinal change over time would definitely help us in decision making.
Yes.
If we get
Yes.
a reasonable signal strength and a reproducible image quality over time.
So Raju,
Okay.
just one comment, if I may.
Yeah, sure, please.
Yeah, okay. So I don't think the Cirrus or any of the OCTs or any machines are designed to tackle the crowds in India. Because one problem that we are having, and we've had now, and I don't know how to go about it, is that with the sheer numbers, and of course COVID was all right, but in the usual thing, the sheer numbers, the machines slow down so much that it is near impossible to get even one image to be exported. It takes about almost 10 minutes and everybody is waiting, and she can't do the next patient because that one is just going round and round. So what Zeiss has done is it has pushed all the raw data into the server, and we just get a snapshot which is exported, which is fine. I mean, we get a GPA, we get an OCT, we get the disk picture, but it's a JPEG snapshot. Now, if you want to do progression analysis, there is no raw data in the machine to analyze. So when you press that progression analysis, it will say there is no data to analyze. And then you have to go back to the server, uncheck it, get the raw data of that patient back, and then do it. So this is just one caveat, that the machines are not robust enough to tackle big data as yet. So that's another limitation that I have, and I spoke to Tanuj, and they face much the same thing. When you have thousands of patients on that machine, that's another problem.
Okay, fine. So I had kept quite few interesting cases, but we don't have much time. So we'll just discuss one case before we finish today's discussion. So non-diabetic hypertensive, is my slide visible?
Yes, yes.
Okay. So patient had come with the vitreous hemorrhage in right eye, was diagnosed PDR in left eye, had PRP, and was referred in December 2019 with the NVI in the left eye. The pressure was 12/26, frank NVI and NVI in left eye. The right eye was normal. And of course, pressures were high, and we started the medical management with Diamox. Pressures were well controlled. The question is that he has unilateral neovascular glaucoma, non-diabetic, poorly controlled. Is his NVG secondary to diabetic retinopathy or not? Anyone? Sachin, you want to take the question? You want to ask me any questions?
This is 58-year-old with your question is whether this is
with patient had a proliferative diabetic retinopathy in both eye.
Okay.
Had PRP and developed NVG only in the left eye. Frank NVG.
Okay.
So my question was that whether the NVG is only because of diabetic retinopathy, or should we look for any other causes?
Yeah, definitely.
In
As
this kind of
if
scenario.
the patient is diabetic and has developed a bilateral PDR with an NVG in one eye, you're always going to look at the circulation also. So in addition to maybe an angiography for the additional CNP areas that you might have missed in your laser, you can also do a carotid Doppler to assess for the circulation to see whether there is an element of ocular ischemia that is involved. So because if you've seen, I think the pressures that you have shown are 14 and 16.
26. 26.
26. Okay, fair enough.
This
Then 26 and
when he came with NVG was 26. 26.
26. Okay, fair enough.
But
in addition to looking at the CNP areas, I would definitely do a carotid Doppler to assess for the circulation, just to treat the coexisting risk factor, because ultimately the treatment of the neovascular glaucoma would be an anti-VEGF laser and followed by a drainage implant if necessary, or maybe a trabeculectomy with MMC if there are no active vessels. But you'll definitely have to look at the workup from the systemic point of view also.
So the doubt I had was that despite both eye having severe PDR, only one eye developed NVG, and that's why we did the systemic workup. And of course, systemic workup is more important because you don't want to miss the systemic causes like the severe carotid insufficiency. And this patient is CT angiography. We did carotid Doppler and CT angiography, which showed severe focal stenosis at the left IC origin with the greater than 90%. And the dense calcific plaques in the distal left CCA bifurcation. So is the main cause of the NVG was not only diabetic retinopathy. His main cause was the severe carotid insufficiency. And we have to remember that whether patient diabetic is not, all NVG is not because of the diabetic retinopathy. It can be severe other causes, and we have to investigate if necessary. So these kind of atypical unilateral presentation, we must have suspicious that there are other causes involved in the neovascular glaucoma, and they do require investigation because this patient also required systemic management. So he had, what I remember, he was advised endarterectomy, but the patient was not interested in surgery, then he lost to follow-up. But this is the thing we have to remember for the other causes of neovascular glaucoma. 75-year-old female patient had present in 2020 with the blurring of vision, had cataract surgery done, no systemic history. Vision was, one eye was 360, 360. This was my fellow working up.
Raju sir, your slides are not moving. Sorry.
So we are seeing the same slide.
Yeah, we are seeing case one.
Is it? It's not moving?
No, it's
So
not
I'll
moving.
just stop and then reshare.
Yep.
Is moving now?
Yes.
Yes.
Yeah. So we did the visual, the disc were 0.6 pale disc, and this is the visual field. Ganesh, you want to comment about the field?
Ganesh is muted. He's muted.
Yeah, this looks, yeah, now it's okay.
Yes,
Please.
Loud and clear.
Good. You did it with a size 5, is it? What about size, the normal?
The left eye vision was 360, so it was not possible to do with the size 3.
Okay.
So we did size 5.
Okay.
And the right eye we could do size 3.
Okay. So it's you don't have the visual field index here. It's quite old, is it?
Yes, it was.
Okay.
It looks more of a neurological.
Yeah, neurological, vertical.
Yeah. So this actually, if you look here, it definitely represents
like a pituitary bitemporal kind of thing. So
yes,
something more of a chiasmal lesion.
Classically vertical. It respects the vertical meridian both sides, though in size 5 also.
Yes.
Yeah, I was gonna say that it looks like pituitary tumor case because we're trying to also understand.
Do you have the disc image?
No, I didn't have disc image. It was pale, 0.6 paler out of proportion in the field. So we did the MRI and it shows very large adenoma. So we sent it to neurosurgeon. They did the surgery, the transnasal microsurgery, and they removed the pituitary adenoma. Patient came back, and this is the field after the surgery.
So the vision improved in the right eye as well as
in both right eye, the left eye, both eye, and the bitemporal heminopia also disappeared.
And you're able to do size 3 now.
Yes, could do with size 3 in
yes,
both
I think this is I think if they've not resected it completely, you will still have to follow up on visual fields, because
Yeah, so
that's one indication that that it's growing again, because they'll never be able to resect it in toto. Yeah.
Completely, yes. So we must follow up the patients, but we must remember that all the field defects are not glaucomatous. There are lots of other diseases involved.
So I had one patient like this who developed pseudoexfoliation glaucoma after that.
Okay.
So again, the whole gamut of things started, whether it is neurological or with pseudoexfoliation glaucoma.
Sir, Ganesh sir, did you find any association in the literature between this bitemporal hemianopic cases and pseudoexfoliation glaucoma?
No. I didn't find any association.
So this is the last case, because I have quite a few, but we are running short of the time. And since we were discussing water drinking test, this is a real case. Pressure was, this is patient had come for second opinion. This is from the old history. The initial pressure was 21, inferior notch, and patient was started on the prostaglandin by Timolol. All the time pressures were 14, but visual field deteriorated. And it shows classic progression. This is, I don't have, because we GPA, because the patient didn't have any spike, but the definite progression. And his pressures were only 14, 15. We checked 2-3 times. His pressures were always around 14 with normal corneal thickness. So this is how I work when the progression happens with the normal pressure. These are the factors I look. Diurnal variation, and we do, I did check the pressures in the night time, and it was 14, 15, not going up more than 16. He was not on any beta blocker, no nocturnal hypotension, no major surgery. Then I asked the systemic history, no sleep apnea. The first time I asked about the rapid consumption, but he was vague. He didn't answer me clearly. But subsequently, he said that he drinks at least 1.5 liters of water every day morning. And I asked him to drink the water and come for the clinic. And his pressures had gone up to 30. So this was the clear cut, the progression secondary to his water drinking. And this was what Sachin was talking about. So this do happen because I think there is a stress to the trabecular mesh, and we must explain the patients that, and we must ask the history, all this detailed history. Sometimes we miss in busy practice. So there are lots of cases I had, but I think we already have crossed. I wanted to finish by 8:25. We already overshot 15 minutes. So I want to.
Can we have one last question, if you don't mind?
Yeah, sure, Sachin. Sure,
yeah,
go ahead.
I wanted to ask everybody about this because it's quite a burning topic. We have a lot of patients of sleep apnea nowadays, which we see. So as far as in case the patient gives you a classical history of sleep apnea, like, it's a disturbed sleep, or maybe, tiredness in the morning, snoring, everything is positive. And he's a patient who's having a glaucoma at normal intraocular pressure. So in such a case, if his sleep study comes with a AHI of say 27, 28 or something like that, then what is the protocol that each one of you all follow? Do you do a CPAP titration? Do you advise a CPAP in such patients? And have you seen any tangible benefit of treating sleep apnea in such patients with normal intraocular pressure progress?
I tend, in your sort of situation, I tend to tell the pulmonologist, I tend to push him towards putting CPAP, even if the pulmonologist thinks it's borderline. But if I have someone whose glaucoma is progressing in a normal tension scenario, I actually sort of push the pulmonologist to see if they can actually be put on CPAP. So I have a few patients on CPAP. So rather than them following their guidelines of having a much higher cutoff, if I have a progressive glaucoma, then I would talk to them and say, listen, do you think it's any harm being on it?
In my
that's my practice.
Yeah. Actually, Dr. Prashant, I agree with you, because in my experience, I had a patient who benefited while referring the patient to for the sleep apneic test. And when the patient came to me, he had a value of the significant loss. And when I send the patient back to the ENT, the treating physician along with the ENT person, the patient was treated for snoring. And later on, the progression, which was occurring at a very frequent, I should say, rate, had reduced and the patient benefited. So to my experience, I think that we can take, I think, a combined effort from the treating pulmonologist or a ENT opinion. Anything definitely will help the patient a lot. If we are on that particular conclusive diagnosis that, okay, the progression is because of the snoring only or sleep apnea only.
Sachin, but I think that they have lots of different parameters they look into other than only AHI. The unfortunate part is that in Mumbai, we have very few the real sleep expert. That's one of the problem.
Actually, the most important parameter they look, I think, is the AHI. That's what because we had a talk by Dr. Prabhu Desai in between, if you remember.
Yeah,
he also said that.
I remember. But Sachin, afterward only I'm telling you, because my friend actually, he's a sleep expert in USA.
Okay.
And I had lots of discussion. He treats only the sleep disorders. He doesn't do anything else.
Okay.
So there are lots of other parameters they look into it. And for CPAP, they are usually the sleep experts. They're quite aggressive. So they don't do. They have lots of other parameters. They look the desaturation point, the lowest point, that how much is going down. The only HI is not important.
Yes.
And not only that, if I have a few patients who are on CPAP now, not only it helps, I'm not bothered about, I'm not talking about glaucoma now.
Yes.
Their diabetes, their systemic blood pressure, that also stabilizes in a much better way once they start the CPAP.
Yes.
So
I
think
they are able to sleep peacefully. I think that is the best part.
That takes care of the health, I think.
Yes, yes.
Any comments, Sushmita madam or Dr. Gauri madam, about your personal experiences on OHA? Because
definitely we have a pulmonologist who is also a sleep specialist close by. And if we say that the glaucoma might be linked to the sleep apnea per se, they are a little bit more aggressive in prescribing the CPAP for the patient. But what I have found is that the acceptance from the patient is also a challenge.
Yes.
Because not many people want to go on the CPAP. Okay, we can explain to them all the advantages, but I have a couple of patients who refuse to go on the CPAP. They don't want to become dependent on it. So that's also a challenge.
Yes, ma'am. Counseling is a major issue, ma'am. That
our ENT department has a sleep lab, so we do send them, and the same, I agree with Prashant that sometimes one has to push it. We are at an advantage that the person running the CPAP is also the husband of one of our consultants, so he doesn't say no to us.
Convenient.
Yeah.
I would agree with Dr. Prashant and Dr. Gauri totally.
Yeah, so I would the Entrode help organizing, the back end work. Any Entrode people on the?
I think Anmol was there, no? Please.
Anmol?
Yes, sir.
So
So would you like to,
before
from
we
your
close-
team, would you like to say anything? Before Dr. Rajul gives vote of thanks, would you like to say anything? Anyone from your team? Mr. Alpesh? So I think you can start with vote of thanks, Rajul.
Okay. So I know this is the first of our series, and I would like to thank Dr. Michael Girard, Gauri, Ganesh, Sushmita, Parul, Sachin, Prashant, Sweta, Shefali, all. It was a really wonderful 100 minutes. I really enjoyed, and thanks for everyone to sparing the time on Saturday evening. And I would hope that we'll see you physically sometime in future when the AIOS comes in June in Mumbai. Thanks everyone. And
Thank you. Thank you for having me.
Everyone.
Thank you all of you here.
Thank you,
Thank you, sir.
ma'am.
Thank
Good
you,
night,
ma'am.
all. Good
Good
night.
night.
Thank you. Good night.
Thank you.
Good
Good
night.
night.
Good night.
there is a message from Anmol Raju. For
Everybody
gallery
left.
view.
He's too late.
Yes.
I think that was, he was trying to arrange that, but he didn't explicitly say that.
Yeah.
Everybody left.
Yeah, Mr. Anmol.